Ankle fractures. Deltoid ligament is a primary strain to the anterolateral talar displacement. External rotation stress radiograph is helped to determine the instability. Medial clear space 5 mm is predictive of deltoid ligament injury. Normal tibiofibular clear space should be less than 5 mm. Normal tibiofibular overlap should be more than 10 mm. Incisuralis fibularis is a concave surface of the distal lateral tibia. Mortise view, assess cut to receive corresponding projection or look to lock parts together. Weight bearing view to identify unstable fractures that is displaced. Row threshold for the CT scan. Weber classification on the level of the fracture in relation to syndesmosis. Weber A, Weber B, Weber C. Weber A below the syndesmosis, Weber B at syndesmosis, C above syndesmosis. Lygonson classification. Supination, adduction injury. There is a vertical fracture of the medial malleus and transverse fracture of fibula. Fibula fails in tension, hence low transverse fracture associated with intermedial marginal impaction. Supination, external rotation injury. Foot is supination and there is external rotator force. First of all, there is a lateral short oblique spiral fibular fracture. In external rotation injuries, fracture is spiral. Fibular fracture runs from anterior inferior to posterior superior. Medial malleus is transverse fractures, and there is posterior inferior tibiofibular ligament injury or disruption of deltoid. Pronation, abduction injury. Medial malleus transverse fracture. In pronation injuries, medial injury first, and then there is a transverse comminuted fracture above the syndesmosis Weber C. Pronation, external rotation injury. Pronated external rotation injury, deltoid ligament is injured or medial malleus. Fibula is a Weber C fracture. Sometimes it could be high Massenet fracture. The fracture is the fracture is going anterior superior to posterior inferior, opposite of supination external rotation injury. Indication for ORIF. This is by Ramsey and Hamilton. 1 mm of talar shift cause increased contact surface on tibio-talar joint by 42%. Number 2, medial / lateral / posterior malleus displacement. Number 3, open fracture. Number 4, posterior malleus more than 25% fragment. Number 5, functional bimalleolar deltoid ligament injury. Bose guidelines assess skin integrity, comorbidities, diabetes mellitus, peripheral neuropathy, PVD, osteoporosis in smoking, urgent reduction, and splintage. Fibula should be fixed on the lateral approach, 10 cm incision, tip of the lateral malleus, superficial peroneal nerve is at risk. Skin incision slightly anterior to aid lax screw fixation between the peroneus tertius and peroneus longus and brevis posteriorly. So peroneus tertius is anteriorly and peroneus longus and brevis posteriorly at the proximal region. Restore the femoral length, lag screw with a new transition plate or a countersink to increase the area of the contact between bone and the screw. Ankle AP X-rays. Check the talocrural angle. This is 79 to 87 degree. Always compare to the opposite side. This angle is made by a tangent line crossing the tibia, a straight horizontal line to the articular surface of the tibia, and then the line joining the fibular tip to the medial malleus tip. And the angle made subtended medially is 79 to 87 degree. Should be checked on the opposite side. Measure Shenton, see the Shenton line. Number 3 is tibiofibular clear space less than 5 mm and tibiofibular overlap more than 10 millimeter. Anti-glide plate is a posterolateral position. The advantage is posterior position allow bicortical screw fixation distally. Plate does not lie directly under the wound, biomechanically superior to the lateral plating. Disadvantage is peroneal tendon irritation. Locking compression plate can be done for osteoporosis and distal fibular fractures. Medium millers cannulated screw 4.0 mm cannulated parallel to the joint. It should cross the physial ridge. Anti-glide pace is possible. Tension band wire is also possible. Major approach is to split the deltoid ligament to allow hardware to seal directly on the bone. Syndesmotic injuries is a positional screw. You can do a cotton test or hook test. Widening of syndesmosis is by pulling the tape fibula after fixation. Will show that syndesmosis is intact or not intact. Lowest rate of false positive results and small inter-observer reliability. Literature is showing that no adverse event of broken screws. Syndesmotic screws, there should be removal in less than 8 weeks lead to tibiofibular diastasis. Direction is from posterior to anterior, 25 to 30 degree, and parallel to the tibial plafond. Tricortical screws just proximal to the tibiofibular joint. Forecortex is easier to remove from medial side if broken. No compression screw threads must be tapped in both fibula and tibia. No compression screw thread must be tapped in both fibula and tibia. 3.5 mm or 4.5 mm screw can be used. Screw loses in 15% or break in 15%. Two small fragment screw in high fibular fractures such as Maisonneuve fractures are also effective. Tightrope or Arthrex, no need for routine removal and eliminates the risk of broken screws. Posterior fractures, some people will prefer to do AP screw fixation, some will go posterolaterally and fix it with a plate. Nailing in frail elderly population, long nail to bypass. Those guidelines for ankle fractures. Number one, stable fracture should be treated with analgesia, splintage, and patient allowed full weight bearing as tolerated. Number two, fracture stability and uncertainty. Mobilize non-weight bearing to review in 2 weeks with X-ray weight bearing. Number three, always check syndesmosis stability during ORIF. Number four, patient should be full weight bearing as tolerated in splint and the cast. Number five, no consensus on removal of syndesmosis screw or VT prophylaxis. Number six, ask patient on functional recovery, rehab, and return to work. Advise patient for recovery, rehab, and return to work. The union rate is doubled in smokers, and a Sweden study has shown that smokers have 6 times higher odds of deep infection, diabetes mellitus, unsatisfactory reduction, and more complicated fracture patterns.